is low. This other bucket is, the lower middle income countries and some low income countries as well. And these countries you see here, Tanzania, Kenya, Ghana, making statements about the importance of, evidence-based selection, priority setting, health technology assessment. And that is basically important because, as I said, even though what they spend on health is very small, and you might argue that the first priority is to increase the size of the pie, they also need to make decisions on what to pay for with the amount of money that they have. And here you see that statement in reality. So, the work that was done by the DCP, basically coming up with a package of interventions that is the essential package for universal health coverage, was budgeted, and the number to cover those interventions is $79 per capita. Now, because it was clear that that was a lot, they went ahead and prioritized the high priority within the priority. So even cutting priority, some priority interventions, and they said the minimum is $40 per capita. But you see that low-income countries spend about $18 per capita. So we're talking about prioritizing among very cost-effective, very relevant and important interventions. And unfortunately, this has to happen, and countries will need to, are faced with very hard trade-offs, especially as we saw, because domestic resources are not increasing, are unlikely to increase because of COVID, and we are expecting reductions in aid budgets as well. So that's the second bucket. So the first bucket, more money, kind of like upper middle or even lower middle income countries. On one hand, health sector reform, and on the other hand, you have other countries who are interested, want to prioritize, make statements on the importance of prioritizing well. And this is basically, how we come to these different entry points. On one hand, you have the priority setting entry point, which is about what you include, what's in, what you exclude, what's out. That has to do with the health benefit package, but also could be, reimbursement lists or essential medicines lists, or programs as well. But you see how some countries get into this more coming from the purchasing angle, trying to be more efficient in their purchasing practices. Strategic purchasing to determine price or price negotiations. The example of Mexico, for instance, using HTA to inform price negotiations. The example of Brazil as well. But there's also a very bottom-up approach, which is clinicians and healthcare professionals trying to improve their own practice and trying to say, what intervention should be provided at what level, what intervention should be included or should be included in the clinical guidelines, or what interventions should just not be included at all. So different entry points and different countries, looking for different things, and we'll go through some of the examples. But there is a problem, a fundamental problem here, which is basically we're moving away from nice, promises and good statements. We're moving away from implicit rationing. We're moving away from, saying everything is covered to being explicit about what's covered and, putting money to those priorities. Of course, you've heard and you've seen in a lot of countries, especially in low-income countries, politicians want to say, we have a policy, all medicines are free of charge. We're doing the work to provide them in public primary care facilities. And that basically is the perception a lot of, citizens have, that yes, there's the statement, but in reality, when you go to the facility, you don't have anything there. Or when you go to the facility, you know, stock out or difficult, the facility is not close to where you are. So the institutionalization of priority setting and, you know, making these priorities explicit basically goes against, you know, the status quo, which is big announcements, which is concentrating on logistics, on availability. You know, in a lot of sub-Saharan African countries, governments are in charge of procuring and are in charge of distributing medicines, are in charge of running the central medical stores, the logistics management information systems. So that all goes to some extent against that trend. So it's not an easy change. In summary, we think, you know, it is extremely important to distinguish, you know, what's, you know, offered in theory with the de facto, what patients get at the point of care. And that there's a big divide, a big difference between the two. And we truly believe that, you know, the de facto is what matters. And we're trying to make that de facto as, you know, positive as possible. How do we get into, you know, supporting a country to institutionalize priority setting and evidence-based priority setting? So this is our theory of change. This is the IBSI theory of change, and I want you to see the center, which is we work on the supply side and we work on the demand side. So we work on the supply side, creating the windows of opportunity, creating the political commitment, creating the buy-in for this to happen. And on the demand side, on the demand side, creating the political commitment. And on the supply side, basically creating the evidence and the capacity to come up with the evidence, working with, you know, the centers that are going to do the assessments, working with, you know, the prerequisites, the building blocks, you know, the costing studies that are needed. And of course, we have, you know, that demand and that supply that will need to be connected. And it's not easy to connect these two. So it has to do with, you know, expectations. It has to do with, you know, time frames, you know, politicians that are, or even technocrats that are interested in using evidence need to make decisions now. And on the other hand, you know, academics want to do an assessment for a year or for 18 months. So that's all part of the difficulties. So working with the demand side, working with the supply side, trying to get networks together to, you know, coming at the end at processes, coming at the end at structures that will basically make these decisions based on evidence and will provide more value for money. So better decisions will lead us to better health. An example, and I'll get into the examples now. You know, in India, IDSI started to work in 2010. So some senior policymaker went to the Prince Mahidol conference in Thailand, saw the Thai example and said, I want to do this. So a lot of support trying to, you know, decide the best way to do it, decide, you know, how the capacity could be built. And finally, after 7 years of support, the Department of Health Research created this body called the Health Technology Assessment Unit or body in 2017. But after that happened, it's interesting to see how that has, you know, really grown. So this HTA unit is functional and works with a network of 26 centers of excellence across India. They have MOUs, it's all publicly funded. They have about 500 people working on it in the whole network. They have 50 positions working on HTA doing studies. They've done more than 25 studies. And that is all great from, you know, the supply side. So the supply is there, the structure is there, the studies are done, the experts are there, we've built capacity. But you will ask me, have these studies been, you know, used to inform decisions? And I have to say, it's a, you know, kind of like a mixed outcome. Sometimes yes, sometimes no, but there's a lot that needs to be done. So we're working with now with the demand on the demand side with the biggest public insurer, which is the National Health Authority they run, this PMJY scheme. Basically, this is a flagship program started by, Prime Minister Modi. Prime Minister Modi, and basically, the idea is, how do they incorporate evidence in deciding what's in the package and deciding what rates they pay hospitals to provide the services. So first, I guess, example, 10 years started with, the supply, and now building a bit the demand, but the linkage is challenging. The second example, and I think this one is an interesting one, is in relation to standalone interventions. So how standalone interventions could be incorporated using this evidence. And we see how, in the Philippines, they created a health technology assessment unit, and they've been able to make the case for the inclusion of vaccines like, HPV or PCV. So that is, success, but limited success, because it's about one intervention, and it's about, making sure that, the right intervention is included. We're working with, several countries on COVID vaccines and how they could or could not pay for different vaccines. And I guess the reflection there is, it has been very hard, because the cost effectiveness of a COVID vaccine is not guaranteed in a country with $20 or $50 per capita of health expenditure a year. So it all comes down to, they will not move, and rightly so, they should not move in terms of procuring themselves. And then you rely on, aid, and you rely on the benefit, the external benefit that vaccinating Africa will have on, the world in terms of global health security and reducing the likelihood of new variants. But again, the example here is not system-wide. It is specific with, some interventions. In Indonesia, the example here is not so positive. So the example here is, they had the big health sector reform, created a public health insurance. They have millions of people insured, and they are basically, already in bankruptcy, or, nearly there. So they have spent much more of what they have. And basically, they saw health technology assessment, explicit priority setting, as a way to, cost contain, and as a way to decide on what's in, what's out, and what's the price. But after the unit was created, after, a few assessments were conducted, they were not able to make the decisions. Or actually, they made the decisions, but they had to reverse the decisions. So these are the numbers that we, produced in combination with the Indonesian colleagues, with the HTA unit there, the HTA, platform there, about, the savings that they could have, the DALIs that they could avert. The decisions were 4 decisions. You can see the decisions at the bottom. But when they made the decisions, the decisions were so unpopular that they just couldn't, go ahead with them. And the lesson here, I guess, is it's not about the assessment. It's not even about the decision. It's about, the process to come to the decision. And the process needs to be seen as, public, inclusive, transparent, participatory, and of course, legally supported. Like in Colombia, we have, and in a lot of Latin America, we have this issue with the judicial system basically overruling priority setting decisions. So you say, this medicine is excluded, and then someone could go to the judge and say, no, this is against my right to health, therefore needs to be provided. And therefore, the problem is there needs to be the legal framework and all these other elements I talked about in terms of process. But all to say this was not successful. And then the other unsuccessful example is Kenya. And you see a lot of traction. President Kenyatta said, affordable healthcare is a priority. We're gonna do this. We're gonna have the universal health coverage pilot, and they said, we're gonna commission, the health benefit package. And what they said is, I need the health benefit package in 60 days. So give me the everything in 60 days. And you might have heard, Edwin Barasa from Cambridge Wellcome Trust saying, it was impossible to do it in 60 days, but they came up with something in 60 days. They reviewed the evidence. They didn't do, health technology assessments from scratch. But at the end of the day, after coming up with a package that, was within budget within 60 days, the government decided to go and do something else. They didn't incorporate the health benefit package on the basis that it wasn't, it was not within budget, even though it was. I mean, I guess all I'm saying is it is not enough to have the window of opportunity. It is not enough to have the demand. It is not enough to have the supply, because at the end of the day, when the tire hit the road, doing this is not, for a lot of politicians, appealing. So I guess just to finalize these initial, reflections, those initial reflections, I think this takes time. It's a bumpy road, as I said. 10 years is what we think it takes, and capacity needs to be created, and it's a continuum. You don't start with cost effectiveness. In a lot of countries, we've started with comparative effectiveness. In a lot of countries, we've started with budget impact. Some prerequisites are needed. So costs sometimes are not available. Data is not available. So, you build all that ecosystem for that window of opportunity to happen. Or sometimes the window of opportunity happens first, and then, you kind of like create the boat as you sail. But creating capacity and doing assessments is not enough. Translation is a key problem. Translation is related to what I said in terms of the legal framework, what I said about, the window of opportunity, but also about the process and the legitimacy of the process. And, we are now very much interested in sustainable, institutions, in making sure that these last once we leave. And that basically means, making sure that there's public investment into these priority setting structures. We are working to try to demonstrate the value of HTA. There have been studies in high-income countries, and there have been some modeling work in middle-income countries. But sometimes, we get the question like, can you really link this work with better health outcomes? And I have to say, a lot of it is intermediary, milestones, and the linkage with, final health outcomes is not always easy to have. So thank you very much, and I'll stop here the monologue, and hopefully we can have a conversation. Over to you, John.
Thank you very much, Javier. It was very interesting. So I'll open it up to questions before I make a comment and ask a question myself. And I'm sure Ian has got a question or a comment, since he's been working in India in the field of oncology.
Sure. Thank you. I enjoyed your talk. I guess one of the things that you didn't say much about was the role of the pharmaceutical industry. I mean, when you gave the example in Indonesia of taking cetuximab and bevacizumab outside of the formulary, I mean, even in high-income countries, as an oncologist, I mean, the benefits of those drugs are extremely marginal. I think we would not have a dent in cancer survival if we didn't use or have available either of those drugs. So it seems common sense that those drugs should not be used in a middle-income country like Indonesia. And as I say, they're questionable even in high-income countries. But I think I would imagine that and I've seen this in India, in Nepal, in Vietnam, that there is a huge amount of pressure from pharma to push their products. And although it's obviously hidden, some of the drugs that do get approved by governments are not the drugs that I would assess as being most effective. And one senses that money is probably changing hands between pharmaceutical companies and politicians to keep things open, and also between pharmaceutical companies and physicians in the case of cetuximab and bevacizumab and various other drugs. And you showed medications were the lead, and that's another big problem, I think. But how do you address those sort of issues? Because it's extremely difficult to overcome the power of these commercial enterprises.
Thank you. I think, you're right, and I agree with you. And that's mainly the case in more mature systems, so upper middle income countries and pharma emerging economies. So you see that in, countries with $500, $600 per capita in health expenditure. You don't see that. I haven't seen that in countries like India, for instance, in terms of the public insurer, because they're just working on a very small budget, and I guess all that this is the public insurer. All the medicines would come through the private out-of-pocket expenditure kind of path. But in terms of what to do, I guess I was with the Colombian government, and we faced the problem. And we knew that the pharmaceutical industry, on one hand, was paying patients to get together and do, patient groups. On the other hand, we knew that physicians were also getting money. Sometimes, money for the number of prescriptions, sometimes more of, education and trips and, some perks. And we thought, there needs to be transparency here. And there needs to be a transparency in terms of how money flows in those relationships. And we saw the example of France and the example of the US with the Sunshine Act. And we put together our own act, and we were able to successfully pass it. But interestingly enough, first, the patients and the physicians were those who were against it. So they didn't want transparency. So it was in so much, dealing with the pharmaceutical industry. It was dealing with all these other stakeholders. And they rightly so, of course, had some concerns about privacy, had some concerns about, perception and about, many other elements. So at the end, we managed to get the act in place. The 2 rounds were voluntary, but then the government changed, and the new government has had a couple of cycles. They have the data, but they have not released it. I guess all I'm saying is that some measures can be put in place, but at the end of the day, you need a very strong government with clear leadership in terms of these are the priorities and this is how we're going to address them. A lot of conversation is taking place now about not just a yes or no decision. That is the conversation, and that's taken from high-income countries that you guys know very well. The risk sharing agreements or the managed entry agreements, or ways to be more explicit about paying for performance, and that's all part of the conversation at the moment. So instead of saying just no, there are ways to provide access to smaller populations, or provide access on the basis of, if it works, I'll pay, otherwise we'll not. Again, this is all longer term, but it is happening. You need to have infrastructure in place in terms of the electronic medical records, the infrastructure to collect the data, collect the outcomes. And it is not easy, I guess, is my in a nutshell answer. And I do take fully your point that is it's not easy.
I mean, on one of your slides, I mean, you obviously had the important point of controlling the demand side, and what you've just said also happens in developed countries, that it's the patients who actually make the demands. And I wondered whether working only looking at HTA with respect to medicines, I wondered how you integrate with other people who are looking at other aspects of healthcare. Ian will know that there was a really interesting article about Costa Rica and their health policy, which has done very well. And one of the key elements there, which actually reduced the demand for medicines, was to provide free school lunches to kids. So there was better nourishment, there was less illness. And I wondered how you integrate with those sort of efforts and kind of more broad aspects of health policy.
You know, I think this is extremely difficult in low middle income countries. I think Costa Rica was successful because they have a very good social, social protection, a good safety net there. It's a centralized system, so there's only one payer. It's a public-based system, so you only have, the caja, and they have a very human development index. But in a lot of the countries, health is health, and health is seen nowadays much more as healthcare, not even social determinants. And health competes with education, and you're looking at health with $50, or health with $100 or $150, and it's just very little what you can do with that. So I think priority setting is important in terms of defining what you go with, but it's not the panacea. And I also think this needs to be included in terms of strategic purchasing, in terms of aggregating demand to reduce prices, in terms of appropriateness, in terms of prescribing, human resources, in terms of medicine, well, doctors being able to prescribe what's right, in terms of transparency, being able to have a frank conversation about, we cannot fund everything, and there needs to be some priorities. Back in Latin America, there is this, it's a very complex issue because we have this growing middle class, we have this, communications, is basically you see what's happening everywhere, and the industry will let you know that these new medicines are very important, or these new technologies can change your life. And we have this complex thing which we call Toyota. Toyota as the car brand, which in Spanish is basically means todo para todos ya, which translates as everything for everyone now. So that's the expectation. So with the growing middle class, that's what you are against. And of course, for this to have a future, there needs to be a process. It needs to be systematic. They need to have everyone needs to have a say. There needs to be a way to and as a society to determine priorities and decide. We just cannot fund these 3, 4 or 5 diseases because we have patient groups advocating for it.
That's very interesting about the growing middle class and their demands. Are there other comments and questions? I'm trying to see.
I would like to make a question. I'm not sure. I'm not mute now.
Yeah, you're on.
Hola, Javier.
Hola.
Such a pleasure. Thank you so much for the talk. That was great. So the question I would like to ask you, please, is about how is global development, the organization, helping, or how is it targeting specific countries? How is that being decided? Because we're talking a lot about low and middle income countries, but I'm wondering whether we're looking at other indicators apart from the GDP, like the inequality coefficient, like the Gini coefficient. Is this something you subscribe to? Is this something you think is worth looking at in terms of whether there's an intervention that could leverage that could level that in a better way, and therefore improve the overall healthcare as a result? Thanks.
Yeah, sure. But this is demand driven. So we get requests from countries. So countries come and say, we're going through this reform, we want you to be here. That has been historically the way. Opportunistic in nature. So, as I said, this high-level politician went to the PMAC conference and met Calypso, and they started working in India. But having said that, we have a process to engage, and that has to do with we do some benchmarking in terms of, is the right window of opportunity there? I mean, can we just have the right partners on the ground to work with? And that also helps in terms of the decision. And the third element is, it also comes from the priority of the funders. So the Gates Foundation, they've been supporting this work historically. Initially, they were interested in Asia. Now they're interested in Africa. And now, they are reducing the number of countries they're interested in. So now, they want you to work in India, in Indonesia, in Kenya, in very few countries. So I guess it's a combination of all these elements. But unfortunately, because it's opportunistic, there isn't a lot of intentionality. So being intentional is something that is not easy to do in the model that we work under.
Thank you.
Yeah.
Yes, it was the reason why I was asking is because of this book that Kate Pickett published a while back, the spirit level, in terms of how inequality affects healthcare outcomes. That was the book that really impacted me as a student. It sort of opened my eyes, like, oh, I had not considered this. So it's always that I'm always looking at in terms of what's that healthcare intervention? Are we looking at this factor? And even here in the UK, NICE is something that it's valued in terms of the health technology assessment. They have a point where they ask, how is this going to affect inequality? Has this been considered? So it's something that perhaps we're not doing enough, and it's worth exploring.
But I have a comment on that, on how you incorporate equity considerations into health technology assessment. Because overall, and I have to say, the model originally was, we just go and do cost effectiveness, we just go and do ICERs, and life will be better, right? But the countries were not really into it. Like, they wanted to, prioritize, kind of like in an informal ad hoc manner. They wanted to prioritize more, certain populations or certain, diseases or certain geographies or certain inequalities. So that wasn't very easy in terms of the model. And of course, looking at the UK and looking at, the cancer fund, or looking at other ways to adjust for other considerations, was not something that, in low-middle income countries, wanted to replicate. So a lot of the conversations have been about, let's use cost effectiveness, but let's consider other elements, like, for instance, what you're saying. And some countries have gone down the path of, MCDA, multi-criteria decision analysis, sometimes in a formal way, sometimes in an ad hoc manner. But I guess the equity considerations are part of the conversation The problem is there's not a systematic way of incorporating that in the assessments as of now.
Other points, questions?
I think Francois.
John, if I may, Javier, thank you very much. It was a fascinating presentation. And apologies, my question may be a bit naive, but I cannot help thinking that all these national priorities and are probably sometimes undermined by the global policies. So my impression it's even more a global problem than a problem of national countries. And the example when you were talking, Javier, is the example which came to my mind is the recent example of the COVID vaccines. And you mentioned this example. We had in a situation of pandemic and global crisis, instead of having a kind of rational approach to the distribution and administration of vaccines, it was a first come, first served basis with massive health inequalities. Even the UK purchasing vaccines from India to administer a booster jab. So, Javier, what are your thoughts on this kind of national initiative undermined by the global behavior of countries?
Yeah, I think that's very interesting. You know, normally the perspective and the entry point is the country. So the idea is, you know, how you use domestic resources in the most appropriate manner. Now, of course, some countries want to incorporate the money coming from the vertical programs and want to incorporate the priorities from, the Global Fund and Gavi and HIV and kind of like presenting a portfolio of interventions funded by different pots of money. But to be fair, they have very little say in, those priorities for that money that is coming from, these global mechanisms. Of course, the things are, changing, or the aspiration is to, be more demand driven. But the fact of the matter is, a lot of the money that is invested in health, at least in low-income countries, is coming from, mechanisms that are sitting in Geneva deciding, what's the best way to provide healthcare for these 3 or 4 diseases. And the problem is, the side effect or the problem with these 20 years of golden global health is the institutions and the health systems on the ground have suffered, and you don't have in low-income countries the ability to, one, the resources, as I showed, and 2, the structures and the governance to make these decisions. So one could argue that this conversation about priorities and allocated efficiency is more relevant for upper middle income countries. And upper middle income countries are those who do have some money and can actually make some decisions on how to invest it and have some structures in place. But the counter argument to that is, with these $40 or $50, you want to make sure that the interventions that are provided are the best possible interventions. But I cannot deny the fact that we are it's like deciding whether you cut your right hand or your left hand. Like you get to a point where it's just the budget envelope is so small that it's just very difficult. And of course, we are talking about going back to the decisions being made elsewhere. It is what it is.
Yeah. No, it's very complicated. I mean, I come back to Ian's point about the power of the pharmaceutical industry actually influencing even pan-national policy. I mean, if you look at some of the policy that's coming out of the European Union on cancer, farmers had a huge impact, and then patients groups as well, who are paid for by pharma. And I feel rather bleak about this. I don't know what you think. I mean, how to get around that, I really don't know. In poor countries, you mentioned, the transformation of Costa Rica. But I think what struck me most, well, one of the things that struck me about what you said is, when you've got a middle class, a growing middle class, they'll want some of the action that they're seeing in wealthy countries. And, the companies will go in there and say, yes, this is a good thing. And how you actually get round that, I have no idea. Education, I guess.
Well, yeah, I think it's a difficult one. I think part of it is having a fair process, having a process where everyone can nominate, everyone can participate. There's a way to have a platform for exchange with consistency, legitimacy, transparency. But I'm not gonna lie. I think it is like trying to prioritize and make decisions with a tsunami kind of like coming your way. And of course, at the end of the day, you see patients and the industry and the process they're successful at highlighting this single patient. And a single patient is kind of like bigger than, thousands or I don't know how many of, millions of people dying from, normal diseases, infectious diseases, or, for not having access to essential interventions. But prioritizing this patient, and it's a hard one. So all I'm saying is, I don't pretend to believe that we've got the answer. We're just trying to, be more systematic to improve the health you get for the money you invest. But the pressures are too strong. I'll give you a bit of maybe of a history. When Colombia was joining the OECD, Colombia was basically, President Santos had two priorities. The first priority was the peace deal. The second priority was to get into the OECD club. So we were defending, our measures in Paris, because the sticky point with the US was basically our pharmaceutical policy. And our pharmaceutical policy in relation to, value for money, priority setting. Of course, some of the questions were, why do you want to, do that from the get-go? We wanted to have that from, marketing authorization. We wanted to, include price related to value at marketing authorization for both public and private. So all to say, the pressure got to that level, that at the end of the day, we had to change our presidential decree to be able to get into the OECD. With the pressure from the US and the Swiss governments. Anyway.
Yeah, an uphill battle. One last comment from anybody.
I think Warren, who is actually working on these issues on the ground, wants to talk. Right. Very good to see you, Warren.
Good. Thank you, Javier. Just interesting, from your experience, what seems to be the low-hanging fruits for institutionalizing priority setting? Is it through benefits package, priority setting work, or through the essential medicines list work? What seems to be working most for low to middle income countries, and where should practitioners and policymakers target their initial engagement with government on institutionalizing a priority setting?
I think that's a very interesting question. I think different entry points for different countries, for different income levels, for different windows of opportunity, for different levels of development in terms of their own structures and processes. I think the lowest hanging fruit is the essential medicines list, but that doesn't have any teeth in terms of, it's a declaration, and sometimes, the procurement agency doesn't even, they have their own list. So a reimbursement list or a procurement list in those countries that still do procurement themselves, Ethiopia, for instance, Ethiopia have a very big, body in terms of procuring medicines. If you're able to, get that list, with, the assessments and the evidence, and you could really improve the health of the population. What we're getting these days, we're getting a lot of requests to do health benefit packages from scratch. So basically, a country has little or has had an attempt to put a package together before, but it hasn't worked. And they think, this is a good way to, go to progress towards universal health coverage. So, that's another entry point. I guess at the moment, for instance, you know this, for instance, in Zambia or in Rwanda or in Pakistan, they've gone down that path, sometimes successfully because, they have money to pay for it, or they have structures to continue updating it. Sometimes unsuccessfully, like in Kenya, like it was just a one-off, it just was not implemented. It's basically a document that it was nicely done in 60 days. Or sometimes, it's a mixed bag like in Ethiopia. But I guess all I'm saying is, and this, it depends on the country, and it's all about, finding that entry point and making it sustainable. Implementing it, I guess, is the important issue for us.
Great, thank you. I think it's fantastic work that you're doing because, as you say, in the last 20 years or a little bit more, these countries are now looking at more seriously at health technology assessments and trying to understand, how best to spend their budgets. So your role is obviously very important in this. So we're up to time. Thank you very much,